Good morning, my dear students. Today we are going to discuss about corticosteroids. In many of our classes, you might have heard about corticosteroids. Steroids are used for this. Steroids are used for decreasing inflammation. Today we will be studying exactly what is steroid, from where it is being synthesized, and the pharmacological action of various steroids that are produced in our body. Now, we have a gland above our kidney, that is the adrenal gland. These adrenal glands produces various classes of hormones that deals with the stress factor faced by animals as well as humans. Okay, now two groups of hormones that are released by them are glucocorticoids and mineralocorticoids, which are necessary for the life. Today we will be studying glucocorticoid as a whole. Okay, glucocorticoid is today's topic. So, in today's class, I will be teaching about the biosynthesis of glucocorticoids, their action, the PK and preparations, the uses, the dosage schedule with and withdrawal, ADR and contraindication, where all you can give and we cannot give steroids, then the precaution during therapy and contraindications. Okay, these are the subheadings we are going to study corticosteroids. Okay, before going into the synthesis, I need to give you a brief introduction about the anatomy, the position, and the three layers of adrenal cortex. Adrenal medulla. Okay, first, one second. Okay, this gland above the kidney is known as adrenal gland. It is divided into cortex and medulla. Two parts, that is cortex and the medulla, and it is the cortex where it is divided into three layers: zona glomerulosa, zona fasciculata, and zona reticularis. These three layers come inside the cortex, and medulla, which is not subdivided. So these three layers are important to us because each layer secretes different hormones. Okay, so the adrenal gland has two parts, that is medulla and the cortex, and this medulla is responsible for the short term management. See, stress is divided into two, that is short term stress and long term stress. പെട്ടെന്നുണ്ടാവുന്ന പേടിയും ഭയവും വരുമ്പോഴത്തേക്ക് നമ്മുടെ ബോഡിയിൽ സെക്രീറ്റ് ചെയ്യുന്ന എന്തൊക്കെയാണ്? അഡ്രിനാലിൻ ആൻഡ് നോർ അഡ്രിനാലിൻ. സോ ഷോർട്ട് ടേം സ്ട്രെസ് ഫോർ മൊമെൻറ്റ് ടു മൊമെൻറ്റ്, ദാറ്റ് ഈസ് ഫൈൻ അഡ്ജസ്റ്റ്മെൻറ്റ്സ് ആർ ഡൺ ബൈ റിലീസിങ് അഡ്രിനാലിൻ ആൻഡ് നോർ അഡ്രിനാലിൻ. Now, there are long-term stresses also. Those are controlled by the other hormones that are secreted by the three different layers of the cortex of adrenal medulla. Now, adrenal cortex is again divided into three layers, that is zona glomerulosa, zona fasciculata, and zona reticularis. As you can see in the picture, the three layers are visible. Okay, now these adrenal cortex releases steroidal hormones that are responsible for the management of long stresses. They are collectively called as corticosteroids. Those hormones that are released from the adrenal cortex are collectively called as corticosteroids, or steroids from the adrenal cortex. Now, the corticosteroids can be classified on the basis of source, from which part of the adrenal cortex and their effect. Okay, they are classified based on the source, or from which part of the adrenal cortex they are being secreted and their primary effect. This is how they are classified. So, under coming to zona glomerulosa. In zona glomerulosa, since they have the salt retaining activity, they release mineralocorticoid, that is aldosterone. They releases aldosterone. Then coming to zona fasciculata. Under zona fasciculata, it is involved in intermediary metabolism, that is glucocorticoids. Glucocorticoids are involved or secreted, or example is hydrocortisone. And the third layer, that is zona reticularis. Here our androgenic or estrogenic activity takes place. In my previous classes, I always told androgens or estrogens are secreted by the adrenal cortex, that is by the zona reticularis. So zona reticularis have androgenic and estrogenic activity, that is dihydroepiandrosterones, which are major sex hormones that is released by the zona reticularis. I hope you got the anatomy. First, adrenal gland is above the kidney. Now that is divided into two, that is the cortex and the medulla. And here cortex is important for us, which is divided into three layers: zona glomerulosa, zona fasciculata, and zona reticularis. And those hormones that are released by these three layers are collectively called as corticosteroids. First, we say zona glomerulosa secretes aldosterone, salt retaining capacity. Zona fasciculata, it has intermediate or intermediary metabolism activity, that it releases glucocorticoids or cortisol. And finally, zona reticularis, which secretes sex steroids or sex hormones, especially our androgen and estrogen. I hope you got the Now, before going into the synthesis of corticosteroids, let me tell you the structure of a steroid nucleus, or what a corticosteroid contain. What do you say? What is the chemical structure of a steroid or corticosteroids? Now, this structure, that is the first ABCD structure, is known as steroid nucleus, or it is known as cyclopentanoperhydro phenanthere ring. This is the basic ring structure that is present in most of the steroid hormones. This is the basic structure that is present in all the steroid hormones. It is a 21 carbon atom. 21 carbon atom that is present for all the steroid hormones. It is otherwise known as cyclopentanoperhydro phenanthere ring, or steroid nucleus. On addition to this, each new corticosteroids are synthesized outside. But the difference between sex hormones are that it only has 18 carbon atom. Here it has this basic steroid nucleus ring, but only 18 carbon atoms will be present. Okay, it won't be having all these bistructures. Increasing the steroid ring numbering will increase the potency and efficacy of each new molecule that is being formed after or synthesized outside. Okay. So here you should know the difference, you should know that corticosteroids have a steroid nucleus, which is a basic structure for all the corticosteroids, and that ring is called as cyclopentanoperhydro phenanthere ring. Now coming to the biosynthesis of adrenal hormones. As I told you, all the corticosteroids are synthesized in the adrenal cortex. Site varnal adrenal cortex aanu. Now what is the starting molecule? From where does these form? They are all formed from cholesterol. നമ്മുടെ കഴിഞ്ഞ ക്ലാസ്സിലെല്ലാം ഞാൻ പറഞ്ഞിട്ടുണ്ടായിരുന്നു, സെക്സ് ഹോർമോൺസ്, ഈസ്ട്രജൻ, പ്രൊജസ്ട്രോൺ എല്ലാം മെയിൽ സെക്സ് ഹോർമോൺസ് ഓൾ ആർ പ്രൊഡ്യൂസ്ഡ് ഫ്രം കൊളസ്ട്രോൾ. അതേപോലെ തന്നെയാണ് ഇവിടെയും the corticosteroids, all the corticosteroids are produced or are synthesized from the starting molecule, that is cholesterol. Now whose control? Under the control of adrenocorticotropic hormone, that is ACTH. As in the picture you see, I'll show you, that is how mineralocorticoid. Now let's see how mineralocorticoid and glucocorticoid and sex hormones are formed. Mineralocorticoid from cholesterol forms pregnenolone under the control of ACTH, which further forms progesterone, that is a female sex hormone, then forms 11-deoxycorticosterone, then cortisone, and finally aldosterone. This is the mineralocorticoid. This is how mineralocorticoid is formed from cholesterol. So the mineralocorticoid from cholesterol is aldosterone. Now after how glucocorticoids are formed in the second layer, zona fasciculata. Glomerulosa, inside the glomerulosa we have aldosterone. Under the second layer it is the glucocorticoid. So after cholesterol gets converted to pregnenolone, 11-hydroxy or 11-alpha OH will convert it into 11-OH pregnenolone. Similarly, progesterone also 11-alpha OH and 11-OH progesterone, which will then gets converted to 11-deoxycortisol and finally cortisol. This is how cortisol is formed in the second layer, zona fasciculata, and finally reticulosa. The last layer reticularis. Last layer reticularis, where sex hormones are formed. This I have taught you in my previous class many times. Dihydrotestosterone and estradiol are formed from the starting element or starting molecule, that is cholesterol. So these are the ways in which our three corticosteroids are formed in their respective layers of adrenal cortex. Okay, the site is adrenal cortex. They are under the control of ACTH, and the starting molecule, or they are synthesized from cortisol. I hope you understood. No need to study this in detail until and unless you need to study the deficiency of different enzymes among these leads to different deficiencies leading to few clinical conditions. Only that time you need to know this flow chart. Otherwise, just understand they are all synthesized from cholesterol. In first layer it is aldosterone, second layer it is cortisol, and third layer it is the sex hormones. As in my previous slide I told you, it is under the influence of ACTH. ACTH is nothing but adrenocorticotropic hormone. It is synthesized and released. Okay, so synthesized and released under the influence of ACTH and pituitary. Okay, and is regulated by CRH, that is corticotropic releasing hormone from the hypothalamus, and by the feedback levels of blood concentration. Same like in my previous slides for all, if there is increase in hormone secretion, there will be negative inhibition to the brain, so that they decreases the secretion of the respective hormones. Now here if you see in the picture, you see when they are released at the time of stress, physical, psychological and environmental stress. These system gets activated, and these hormones are being released in the body under the influence of ACTH. Okay, this is a picture of the HPA or hypothalamic pituitary axis. Here I will show you, or I will tell you what the biosynthesis and the feedback regulation of corticosteroid. In this picture I will show you the biosynthesis plus the feedback mechanism. From the HPA axis, and they need a stimulation. That stimulation is nothing but stress. Stress will include injury, hemorrhage, severe infection or after any major surgery, hypoglycemia, pain, fever or extreme cold. All these will induce stress and stimulate the higher center, that is the hypothalamus. Here hypothalamus will get stimulated under the influence of CRH, that is corticotropin releasing hormone, will activate the anterior pituitary, which secretes the ACTH. Under the ACTH influence, the adrenal glands get stimulated. In the adrenal gland, the adrenal cortex gets stimulated, and they secrete the hormone cortisol from the second layer, that is glomerula fasciculata. From there cortisol is being released, and they does the metabolic effect. For the stress relief action over cheyunnu. That is how the HPA axis takes place. This picture should be remembered. And from the action, after the metabolic effects are taken place, after the action, the stress factor decreases. So there is a negative inhibition, stress decreases, and the activation will be decreased. Now this picture should be remembered, because it's as we go further, I will I will be just explaining the HPA axis. This is the HPA axis. So when I mention HPA axis, this picture should come into your mind. Okay, this is just nothing but the how it is being secreted from the hypothalamus, how corticosteroids are being secreted from the hypothalamus. Now here in regulation, you should remember there is a circadian rhythm for corticosteroids, that is especially the cortisol, that is it is being secreted at a larger or higher amount only in the early morning time, that is from 6 o'clock to 10 o'clock in the morning. The secretion of corticosteroid takes place, especially cortisol. In the night all it decreases off. Okay, their secretion is mostly higher at the early morning to in the early morning. Just remember, in the early morning their secretion is at the higher level. Okay, coming to the mechanism of action of glucocorticoids. Corticosteroids have two types of receptors. One is glucocorticoid receptors and mineralocorticoid receptors. In this picture I am showing you about glucocorticoid receptors. Now those red balls are glucocorticoids. Now in glucocorticoids, you understand one thing, that they are cytoplasmic receptors which are widely and uniformly distributed in all tissues. You will see their receptors in all the tissues. Now this receptor, that is glucocorticoid receptor, has three domains. That is one is for glucocorticoid binding itself, that is glucocorticoid binding domain. Second is for DNA binding domain, and the third one is for receptor regulatory domains. So it has three domains in the shape of a finger. This is otherwise known as zinc fingers, because it is stabilized by zinc ions. So it can be otherwise also known as zinc fingers, stabilized by zinc ions. or else it is otherwise known as glucocorticoid receptors in the form of 3 fingers. Here, now this GR or glucocorticoids is always kept in a inactive state by the heat shock proteins or immunophilins that will come and bind to the third domain I told you, that is the receptor regulatory domain. When they are bound, the receptor regulatory domain are bound with HSP or immunophilins, they are in the inactive state. Suppose the glucocorticoids come or are released into the body, they move towards the cytoplasm, come and binds to the first domain, that is glucocorticoid binding domain. These will be released out. These heat shock proteins will be released out and they form a complex, that is steroid receptor complex. Who forms the steroid, that is our glucocorticoid plus the GR forms a complex, that is steroid receptor complex. Now this will move towards the nucleus. This moves towards the nucleus where it will come and interact with the GRE. GRE is nothing but glucocorticoid responsive element which has a specific sequence of chromatin on chromatin. Now this GRE also has a duplicate sequence which is suitable to combine with the SR, that is steroid receptor complex. As a result of this binding, it affects the transcription process either by causing co-regulators, either by initiating the transcription, co-activating the transcription, or inhibiting the transcription, or by suppressing the transcription. Depending upon what response is required, the action takes place after the binding of the SR complex with the GRE. This is how the action of glucocorticoids takes place. Either it can induce or it can suppress, okay, depending upon the binding or depending upon the need of the body. I hope you understood with the glucocorticoid receptor that which comes and binds to the nucleus. Which comes and bind. In your UG level, just understand it is a cytoplasm. GR is a cytoplasmic receptor which is usually or widely distributed around in the whole body, where the glucocorticoid after binding to GR receptor moves towards the nucleus. Only that much is important. Baki all are what you say കുറച്ചുകൂടെ molecular level ലോട്ട് പോകുന്ന പാർട്ടാണ് ഞാൻ പറഞ്ഞത്, just for a knowledge only. Maybe in your PG exam, if PG NEET is there, they might ask you few questions from that. That's it. Now I told you the second nuclear receptor, that is corticosteroid രണ്ട് receptor ഉണ്ടെന്ന് പറഞ്ഞു, glucocorticoid receptor, mineralocorticoid. And the mineralocorticoid, it is not widely distributed like the GR, but where all it is expressed is one, where there is transport of electrolytes, that is the kidney, colon, salivary glands and the sweat glands. Also it is present in other tissues which do not have a well defined action, that is heart, adipose tissue and CNS, especially in the hippocampus. The mechanism of action of MR is also similar to our GR, that is similar to glucocorticoid receptors, except for its site എല്ലായിടത്തും കാണത്തില്ല, except for places which are concerned with the transport of electrolytes. അവിടെ മാത്രമേ നമ്മുടെ MR അതായത് mineralocorticoid receptorsന്റെ action കാണത്തുള്ളൂ. Okay, I hope you understood with the mechanism. Coming to the actions of each corticosteroids, നമ്മൾ ഇന്ന് രണ്ട് കാര്യങ്ങൾ മാത്രമേ നോക്കത്തുള്ളൂ, mineralocorticoid and glucocorticoid. I have taught you about sex steroids അല്ലെങ്കിൽ sex hormones in my previous class. 3-4 ക്ലാസ് എടുത്ത് പഠിപ്പിച്ചതാണ്. ഇന്ന് നമ്മൾ mineralocorticoid glucocorticoidന്റെ ആക്ഷൻസ് നോക്കും. Under mineralocorticoid, what are the effects of mineralocorticoid on sodium, potassium and fluid balance? ഇത് 3 കാര്യങ്ങൾ നോക്കും. അതുകൂടാതെ glucocorticoids on carbohydrates, proteins and fat and the other activities that glucocorticoid will be doing. Okay, coming to the mineralocorticoid actions, as I told you, sodium എന്താ ചെയ്യുക? It enhances the absorption of sodium from the distal convoluted tubule. Okay, distal tubule increases the absorption of sodium, so sodium retaining capacity ഉണ്ടാക്കുകയാണ്. Increased excretion of potassium and hydrogen, expels out potassium and hydrogen. And also this action is similar to colon, sweat glands and salivary glands. ഞാൻ നേരത്തെ പറഞ്ഞ പോലെ എല്ലാ സൈറ്റിലും mineralocorticoid receptors കാണത്തില്ല. കാണുന്ന സ്ഥലങ്ങളിലാണ് ഞാൻ പറഞ്ഞത് colon, sweat glands, salivary glands കാണാം. അവിടെയും ഇതേ സിമിലർ ആക്ഷൻ ആയിരിക്കും. They enhances the absorption of sodium but increases the excretion of potassium and hydrogen. Okay, coming to the extremes of aldosterone. Extremes of aldosterone are two sides of aldosterone. Either what will happen if there is an increase in aldosterone, or what will happen if there is a deficiency of aldosterone. Before going into that, once again I will repeat here, the main effect of mineralocorticoid, that is aldosterone, is sodium water retention by reabsorption of sodium and along with that excretion of potassium and hydrogen. Excretion of potassium and hydrogen. Okay, in deficiency, what will happen if there is a deficiency? Deficiency of corticosteroid will result in deficiency of sodium. As a result, there will be decreased sodium level. There is loss of circulatory volume. This will lead to absorption of water without associated sodium absorption, and therefore dilutional hyponatremia and changes due to hyponatremia. Sodium illada varuna oru avasthayil, sorry, aldosterone illada varuna oru avasthayil what will happen? Sodium നമ്മുടെ ബോഡിയിൽ റിട്ടെയിൻ ചെയ്ത് കാണത്തില്ല. ദിസ് വിൽ ഫൈനലി ലീഡ് ഇൻ ടു ഡൈല്യൂഷണൽ ഹൈപ്പോനാട്രീമിയ. ഓക്കെ, ദെൻ ദർ ഇസ് പിന്നെ നമ്മൾ പറഞ്ഞ പൊട്ടാഷ്യം ഇതും ലൂസ് ചെയ്യാണ് നോർമൽ ഫങ്ഷൻ ഓഫ് ആൽഡോസ്റ്റെറോൺ. സപ്പോസ് ഇറ്റ് ഇസ് ദാറ്റ് ആൽഡോസ്റ്റെറോൺ ഇസ് നോട്ട് പ്രസൻറ്റ്, ദെൻ ദർ ഇസ് അസോസിയേറ്റഡ് റിട്ടൻഷൻ ഓഫ് പൊട്ടാഷ്യം ആൻഡ് ഹൈഡ്രജൻ ദാറ്റ് വിൽ ലീഡ് ടു ഹൈപ്പർകെലീമിയ ആൻഡ് അസിഡോസിസ്. അതാണ് സെക്കൻഡ് പോയിന്റ്. That is written in red color. Red color decrease ആണ് കാണിക്കുന്നത് കേട്ടോ. There is or deficiency. What happens if there is deficiency? And finally, if there is again deficiency of corticosteroid, that is aldosterone, prolonged it will lead to circulatory failure in cases of hypocortism or adrenal insufficiency. അങ്ങനത്തെ condition leads to what you say, circulatory failure, and survival of the patient may be difficult. Okay, this is what happens if there is deficiency of aldosterone: dilution, hyponatremia, hyperkalemia, acidosis, and massive loss of sodium, and decreased extracellular fluid volume. That is nothing but circulatory failure, leading to circulatory failure. Now suppose if there is prolonged usage of aldosterone or increased secretion of aldosterone in the body. Okay, this may how നമ്മൾ എക്സ്റ്റേണലി കൊടുക്കുകയാണെങ്കിൽ, ഡോസ് കൂട്ടി കൊടുക്കുകയാണെങ്കിൽ, അല്ലെങ്കിൽ പ്രൊലോങ് യൂസേജ് ഇൻ എനി ഡെഫിഷ്യൻസി കേസ് നമ്മളിതിൻ്റെ എക്സ്റ്റേണൽ അഡ്മിനിസ്ട്രേഷൻ ഉള്ളപ്പോഴത്തേക്ക് ദർ ഇസ് sodium water retention and increased circulatory volume and hypertension. Due to this reason, corticosteroids should be avoided in hypertensive patients. Sodium water retention ചെയ്യുന്നത് കൊണ്ട് അങ്ങനെയുള്ള പേഷ്യൻസിന് ബി പി കൂടാനുള്ള സാധ്യതയുണ്ട്. So that because of this, with caution, contraindicated ആണ് hypertensive patientsന് കൊടുക്കുന്നത്. So otherwise it can cause positive sodium balance with expansion of ECF, increased sodium plasma, hypokalemia, and alkalosis with hypertension, and also it can cause myocardial fibrosis. So, okay, these are the extremes of aldosterone, that is either deficiency or increase in aldosterone in the body. Coming to glucocorticoid action, that is glucocorticoid action on carbohydrate metabolism. On carbohydrate metabolism, the main effect is on the glycogen synthesis. They stimulate enzyme hepatic glycogen synthase and causes deposition of glycogen in the liver, and also helps in gluconeogenesis. Now, it also inhibits the uptake and utilization of glucose in the peripheral tissues, and thereby causes hyperglycemia. So inhibits glucose utilization, causing hyperglycemia, giving a diabetic like state. So നമ്മൾ ഒരു കാര്യം ഓർക്കേണ്ടതെന്ന് വെച്ചാൽ, നമ്മൾ സ്റ്റിറോയിഡ്സ് ഡയബറ്റിക് പേഷ്യൻറ്റ് കൊടുക്കുമ്പോൾ സൂക്ഷിക്കുക. വൈ? ബിക്കോസ് അവർക്കൊരു ആക്ഷൻ എന്ന് വെച്ചാൽ ഡയബറ്റിക് ലൈക്ക് സ്റ്റേറ്റ് ആണ് പ്രൊഡ്യൂസ് ചെയ്യുന്നത്. അപ്പോൾ ഡയബറ്റിക് ആയിട്ടുള്ളൊരു പേഷ്യൻറ്റ് കൊടുക്കുമ്പോഴത്തേക്ക് ഇറ്റ് ഇൻക്രീസസ് ദി സിറ്റുവേഷൻ ഇൻ എ ഡയബറ്റിക് ലൈക്ക് പേഷ്യൻറ്റ്, ഇറ്റ് കോസസ് ഹൈപ്പർഗ്ലൈസീമിയ. ഓക്കെ, സോ with caution you should give glucocorticoids in a diabetic patient. Now coming to the protein metabolism. Protein metabolismത്തിൽ steroidsന്റെ action എന്താണ്? The proteins are broken down and the released amino acid are utilized for synthesis of glucose. അവിടെ വീണ്ടും ഗ്ലൂക്കോസ് ഉണ്ടാവുകയാണ്. That is gluconeogenesis. Now the protein breakdown, that is the catabolic effect. Above, glucose has a catabolic effect on protein. This will lead to various changes depending upon the tissue where the protein is broken down. എവിടുന്നാണ് protein break ചെയ്യുന്നത് അതനുസരിച്ചിരിക്കും അവരുടെ action. Suppose if it is from the muscle, it causes muscle wasting. If it is from the bone, it causes osteoporotic changes. And if it is in the skin, it causes thinning of the skin. And the catabolic changes in the lymphoid and the connective tissue. There is a negative nitrogen balance due to excess urea production. As a result, tissues breakdown ആണ്, urea production ഉണ്ടാവും, negative ഒരു iron balance ഉണ്ടാവും. So if I summarize the protein metabolism of corticosteroids, they causes protein breakdown, that is a catabolic effect and mobilizes amino acid from peripheral tissues. Now depending upon the site, if it is a muscle, it causes muscle wasting. If it is the bone, it causes loss of osteoid from the bone, and if it is the skin, it causes thinning of the skin. So as a result, there is excessive urea production and leading to a negative nitrogen balance. Also uric acid excretion increases. Okay, fat metabolism. In fat metabolism, they stimulate hormone sensitive lipase and lipolysis. Plus the lipolytic activity of adrenaline, glucagon, growth hormone and thyroxine is facilitated. That is, there is permissive action or permissive effect. What do you mean by permissive effect? A permissive effect is in which the presence of one hormone enables the other hormone to act. അതായത് നമ്മുടെ ഗ്ലൂക്കോകോർട്ടിക്കോയിഡിൻ്റെ പ്രസൻസിൽ ഇവരുടെ ആക്ഷൻ നടക്കാൻ സഹായിക്കും. All these permissive action of all these hormones are lipolysis, that is breakdown of fat, and also it increases the breakdown of triglycerides. Now in subcutaneous tissue will lipolysis takes place and they get redistributed. These fats go redistributed in different area of the body, leading to or get deposited over the face, neck and the shoulder region, leading to a special typical sign known as Cushingoid syndrome, which includes the moon face, buffalo hump and fish mouth. This is a typical feature of a Cushingoid baby or Cushingoid person who has increased cortisol in their body, or there is endogenous hypersecretion of this hormone. This is due to the breakdown, fat breakdown നടക്കുകയും ചെയ്യുന്നുണ്ട്. അതുകൂടാതെ ഈ ബ്രേക്ക്ഡൗൺ ചെയ്ത് ബാക്കി ഭാഗത്ത് പോയി റീഡിസ്ട്രിബ്യൂട്ട് ചെയ്തിട്ട് ഇങ്ങനത്തെ പിക്ചർ തരികയും ചെയ്യുന്നുണ്ട്. ദാറ്റ് ഈസ് മൂൺ ഫേഷീസ്, ബഫലോ ഹംപ് ആൻഡ് ഫിഷ് മൗത്ത്. Coming to the calcium metabolism. This in calcium metabolism, there is inhibition of intestinal absorption and promotion of excretion of calcium, loss of calcium from the bone, negative calcium balance and spongy bones, which will be more vulnerable to fracture. Coming to the water excretion and stomach, ഞാൻ കുറച്ചുകൂടെ സ്പീഡിൽ പോകാം. ഇതൊക്കെ ജസ്റ്റ് നിങ്ങൾ വായിച്ച് മനസ്സിലാക്കേണ്ട കാര്യങ്ങളാണ്. Water excretion and the stomach, it helps to maintain water excretion in the kidney. It helps to maintain the normal GFR. In adrenal insufficiency, അതായത് adrenal insufficiency, capacity will be lost and water intoxication. Water excretion നടക്കില്ല, അതുകൊണ്ട് there is water intoxication. In the stomach, if you see, gastric acid and pepsin secretion will be increased and it may cause peptic ulcer. So corticosteroid drug കൊടുക്കുകയാണെങ്കിൽ, one thing you should remember, pepsin and gastric acid secretion will be increased, that may aggravate peptic ulcer. അപ്പോൾ acid peptic disease ഉള്ളവർക്ക് നമ്മളിത് കൊടുക്കുമ്പോൾ സൂക്ഷിച്ചു കൊടുക്കണം. ഓക്കെ, again coming to the cardiovascular system. Cardiovascular system first ഞാൻ പറയുന്നത് permissive role on pressure effect of adrenaline and angiotensin. Permissive action എന്ന് വെച്ചാൽ, what do you mean by permissive effect? That is, the permissive effect is in which the presence of one hormone enables another hormone to act. നമ്മുടെ ഈ പറയുന്ന corticosteroid helps the actions of adrenaline and angiotensin to come into its full effect. Full effect ഇവരെ സഹായത്തോടെ പറ്റും. So the vasopressor effect of adrenaline and angiotensin is facilitated and this may cause hypertension. അപ്പം ഇത് കാരണം അവർക്ക് hypertension ഉണ്ടാകാനുള്ള സാധ്യതയുണ്ട്. Second, it maintains a tone of arterioles and myocardial contractility. Now in adrenal insufficiency, it will lead to low cardiac output and arteriolar dilatation with a poor response to adrenaline. Finally, cardiovascular collapse along with mineralocorticoid. Mineralocorticoid can lead to cardiovascular collapse. ഞാൻ നേരത്തെ mineralocorticoid actions പറഞ്ഞു. As a result, it can lead to cardiovascular collapse. Okay, coming to skeletal muscles. Now the normal muscular activity requires physiological concentration of corticosteroids, and muscle weakness is observed in both hypocortism, that is due to decreased circulation of corticosteroid, and also in hypercortism, where there is increased or excess administration of corticosteroid. അപ്പോൾ രണ്ട് സിറ്റുവേഷനിൽ ഹൈപ്പോകോർട്ടിസത്തിലും ഹൈപ്പർകോർട്ടിസത്തിലും രണ്ടിലും മസിൽ വീക്ക്നെസ് കാണുന്നതായിരിക്കും. ഇൻ ഹൈപ്പർകോർട്ടിസം ദർ ഇസ് ഡിക്രീസ് വർക്ക് കപ്പാസിറ്റി ആൻഡ് വീക്ക്നെസ്. ഹൈപ്പോ എന്ന് പറയുമ്പോഴത്തേക്കും റിലീസ് കുറച്ച് ഉള്ള സിറ്റുവേഷൻ, where there is glucocorticoid decrease. Hypercortism, there is excessive mineralocorticoids, that is aldosterone കൂടിക്കഴിഞ്ഞാൽ hypokalemia weakness ഉണ്ടാവും. And also if there is glucocorticoid excess ഞാൻ പറഞ്ഞു, protein breakdown ഉണ്ടാവും. മസിൽസിലാണെങ്കിൽ muscle wasting, weakness and myopathy. This is what are the changes that takes place in the skeletal muscles. Okay, skeletal muscles, muscle wasting weakness and myopathy in excess hormones. Coming to CNS, in therapeutic doses, mild degree of euphoria, that is a sense of well-being, is observed irrespective of relief in symptoms of the disease. Okay, so mild euphoria, there is increased motor activity. Some may experience with insomnia, hypomania or depression. Other behavioral disturbance may occur in higher doses and also with prolonged use, such as anxiety, insomnia and increased muscular activity. ഞാൻ നേരത്തെ പറഞ്ഞ കാര്യങ്ങൾ ഒക്കെ കുറച്ചുകൂടെ higher dosesലാണ് കാണുന്നത്. They also lowers the threshold, seizure threshold. Some patients with Addison's disease may experience apathy, depression and psychosis. Coming to the lymphoid tissue, what happens is that they act mainly on multiple components of the cellular immunity, and they have very little effect on the humoral immunity. Now, the primary antibody response is diminished with the continuous use of the previously established antibody response will be reduced. Okay, and these all takes place through multiple mechanism. Now, in the presence of malignancy of lymphatic cells, that is like lytic actions are significant. Apoptosis will be increased, especially, and so they can be used in lymphomas. Since apoptosis, that is killing process, is increased, they can be used in lymphomas. Then minor effects on hemoglobin and RBCs helps to protect against hemolysis of RBC, because they help in the increase in the number of RBC. Also, it decreases the number of circulating lymphocytes, monocytes, eosinophils and basophils, but increases polymorphs. So, what are the changes in the lymphatic tissues? Apoptosis കൂട്ടുന്നത് കൊണ്ട് മാലിഗ്നൻസിയിൽ ഉപയോഗിക്കാൻ പറ്റുന്നുണ്ട്. Especially they used in lymphomas. That is the base of the use. And കാരണം ഉപയോഗിക്കാനുള്ള കാരണം അതുകൊണ്ടാണ്. ചില മാലിഗ്നൻസീസിൽ നമ്മൾ സ്റ്റിറോയിഡ് ഉപയോഗിക്കുന്നത് എന്തുകൊണ്ടാണ് എന്ന് ചോദിക്കുമ്പോഴത്തേക്കും it is because it increases apoptosis. Few of the cancer cells can be killed. Then RBCയിൽ minor effects ഉണ്ട്. It increases the number of RBC. Okay. Now coming to the inflammation part നോക്കുവാണെങ്കിൽ glucocorticoid are potent anti-inflammatory and reduces all type of inflammation regardless the cause, as they act in multiple mechanism. നമ്മൾ എവിടെയെങ്കിലും ഒരു നീരോ ചതവോ എന്തെങ്കിലും വരുവാണെങ്കിൽ പെട്ടെന്ന് നമ്മളൊരു സ്റ്റിറോയിഡ് കൊടുക്കും, because it has an anti-inflammatory action. Now, അതെങ്ങനെയാണെന്ന് നോക്കുവാണെങ്കിൽ how they act. They inhibit the various effects of they inhibit the effects of various mediators that causes inflammation, and the effect that is the effect on the leukocytes, chemokines and cytokines. The inflammatory process including the production of intracellular adhesion molecules such as endothelial leukocyte adhesion molecule, that EALAM and ICAM, all are reduced. These effects are important for leukocyte localization and are inhibited by glucocorticoids. ഈ ഇൻഫ്ലമേറ്ററി പ്രോസസ്സ് ഉണ്ടാകുന്ന എല്ലാ സംഭവങ്ങളെയും അവരങ്ങ് ഇൻഹിബിറ്റ് ചെയ്യുകയാണ്, and so thereby acting as a potent anti-inflammatory agent. So they act by preventing migration of leukocytes, prevent chemotaxis and lysosomal enzyme synthesis, diminishes the production of prostaglandins, leukotrienes, platelet activator factor and histamine release, and also it stabilizes lysosomal membrane, preventing spillage of lysosomal enzymes. ഞാൻ നേരത്തെ പറഞ്ഞ പോലെ കുറച്ചുകൂടി ഡെപ്തിൽ പോവുകയാണെങ്കിൽ അഡ്ഹഷൻ മോളിക്യൂൾസിനെ എല്ലാം ഇൻഹിബിറ്റ് ചെയ്ത് കഴിഞ്ഞ് they helps in anti-inflammation. Okay. Okay, immunological actions impairs immunological competence, and also it suppresses all type of hypersensitization and allergy, and causes suppression of CMI, that is cell-mediated immunity, delayed hypersensitivity and graft rejection, inhibition of the interleukin-1 and interleukin-2, suppresses natural killer cells. നമുക്കിപ്പം സപ്പോസ് നമുക്ക് എന്തെങ്കിലും അലർജി വരികയാണെങ്കിൽ നമ്മൾ ആദ്യം ചെയ്യുക, സപ്പോസ് ബീ സ്റ്റിങ് അല്ലെങ്കിൽ എന്തെങ്കിലും ഒരു അലർജിക് picture occurs in our body, നമ്മൾ ഫസ്റ്റ് ലോ മൈൽഡ് ഡോസ് ഓഫ് സ്റ്റിറോയിഡ് കഴിക്കാം, because it helps or suppresses all kind of allergic reactions in the body and prevents the further production of all these chemokines and leukotrienes, thereby the action is further stopped. So these are the actions of glucocorticoids and various systems. Miscellaneous ആയിട്ട് ഓർക്കാനുള്ളതെന്ന് വെച്ചാൽ യൂറിക് ആക്ഷൻ, നോൺ സ്പെസിഫിക് ആൻറ്റിപൈററ്റിക് ആക്ഷൻ, ആൻഡ് ഓൾസോ സ്ട്രക്ചറൽ ആൻഡ് ഫങ്ഷണൽ മെച്ചുറേഷൻ ഓഫ് ഫീറ്റൽ ലങ്. ഫീറ്റൽ ലങ്ങിന്, ദാറ്റ് ഇസ് വയറ്റിലുള്ള ഫീറ്റസിന് ലങ്ങിനെ മെച്ചുറേഷന് സഹായിക്കുന്നുണ്ട്. Fetal secretion of cortisol regulates the maturation of fetal lung and is required for the production of pulmonary surfactants necessary for normal breathing, and thus in cases of premature delivery, large amount of betamethasone, which is a steroid, is administered. അതുകൊണ്ടാണ് സ്ട്രക്ചറൽ ഫങ്ഷൻ മെച്ചുറേഷൻ ഓഫ് ഫീറ്റൽ ലങ്ങിനെ കുറിച്ച് പറയുന്നത്. സോ സപ്പോസ് ഇഫ് ദർ ഇസ് എ പ്രിമച്വർ ഡെലിവറി, ഇഫ് യു സസ്പെക്ട് ദ ലേഡി ഗോസ് ഇൻ ടു പ്രിമച്വർ ഡെലിവറി, ഫോർ ദി മെച്ചുറേഷൻ നമ്മൾ 36 വീക്സ് കഴിഞ്ഞിട്ടേ, 34 to 36 വീക്സ് കഴിഞ്ഞിട്ടേ നമ്മുടെ സർഫാക്റ്റൻസ് വിച്ച് ഇസ് റിക്വയർഡ് ഫോർ നോർമൽ ഫങ്ഷൻ ഓഫ് ദ ലങ് പ്രൊഡ്യൂസ് ചെയ്യത്തുള്ളൂ. ഫോർ ദാറ്റ് പ്രൊഡ്യൂസ് ചെയ്യില്ല, അല്ലെങ്കിൽ പ്രിമച്വർലി ലേഡി ഡെലിവറി ചെയ്യും എന്നൊരു ഇത് വരുവാണെങ്കിൽ വി ഗോ ഗിവ് ഹൈ ഡോസസ് ഓഫ് ബീറ്റമെത്തസോൺ സോ ദാറ്റ് there is fetal lung maturation which may help the baby to respire after the baby is born. Coming to the pharmacokinetics or PK, therapeutically this drug can be given in all the forms, that is orally it can be given IM, IV and topically. ടോപ്പിക്കലി എന്ന് പറയുമ്പോൾ നമ്മുടെ സ്കിൻ ഡിസീസിനുള്ള ഏതൊരു ക്രീംസും കോൺടാക്ട് ഡെർമറ്റൈറ്റിസ് അങ്ങനെ വരുമ്പോഴത്തേക്കും നമ്മളൊരു സ്റ്റിറോയിഡ് കണ്ടന്റ് മിക്സ് ചെയ്തൊരു ക്രീമായിരിക്കും പുരട്ടുക. Now, hydrocortisone, one drug, one form of steroid, it undergoes high first pass metabolism. Then oral bioavailability of synthetic corticoids, അതായത് സിന്തറ്റിക്കലി ഉണ്ടാക്കുന്ന synthetic corticosteroids are very high, so it is very good orally. Now, both endogenous ഉള്ളിലുള്ളതും അല്ലാതെ നമ്മൾ വെളിയിൽ നിന്ന് കൊടുക്കുന്നതും, both the glucocorticoids will come and bind to corticosteroid binding globulins. Okay, synthetic steroids undergo reduction in the liver to form active compounds, and they are metabolized in the liver and excreted through urine. Exogenously, വെളിയിൽ നിന്ന് നമ്മൾ സപ്ലൈ ചെയ്യുന്ന administered hydrocortisone will has a T-half of 1 to 1.5 hours. 1 to 1.5 മണിക്കൂർ വരെയാണ് അവരുടെ T-half. Now coming to the individual agents. First one, hydrocortisone. Or it is otherwise known as cortisol. Now, what rapid but short acting with significant mineralocorticoid activity, അതായത് ഒരു corticosteroid ആണ് with a rapid but short acting with some mineralocorticoid activity. They are used for the replacement therapy when there is absence or deficiency of the above hormones, plus it is used in shock, status asthmaticus and adrenal insufficiency. Status asthmaticus ൽ കുറച്ച് അലർജിക് റിയാക്ഷൻസ് ഉണ്ടാകുന്നുണ്ട്. അലർജിക് റിയാക്ഷൻസിനെ പ്രിവെൻറ്റ് ചെയ്യാനായിട്ട് നമ്മളിത് കൂടുതൽ കൊടുക്കാറുണ്ട്. ആൻഡ് ഓൾസോ പെട്ടെന്നുള്ള ആക്ഷൻ ആയിരിക്കും, റാപ്പിഡ് ആക്ഷൻ ആയതുകൊണ്ട് കൂടാണ് സ്റ്റാറ്റസ് ആസ്മാറ്റിക്കസിൽ നമ്മൾ കൊടുക്കുന്നത്. ടോപ്പിക്കലി ആൻഡ് ഓൾസോ ആസ് എനിമ ഫോർ ulcerative colitis. Okay, these are the function of hydrocortisone. Coming to the next preparation, അല്ലെങ്കിൽ the next agent, that is prednisolone. Prednisolone more potent than hydrocortisone, has more glucocorticoid activity. നേരത്തെ പറഞ്ഞ ആൾക്ക് കുറച്ച് glucocorticoid activity ഉള്ളൂ when compared to prednisolone. This has a more glucocorticoid activity, intermediate duration of action and less HPA axis suppression. Remember this term. I will be teaching this in the later slides. Less HPA axis suppression. And also it is used in allergic inflammatory condition, autoimmune diseases and malignancy. Our immunological response, it reduces the immunological response, so that it can be used in immunological disease. So here prednisolone is mostly used in autoimmune diseases and malignancy. Coming to methylprednisolone, more potent and more selective, can cause retention enema used as retention enema in ulcerative colitis, pulse therapy in non-responsive rheumatoid arthritis, helps in renal transplant and pemphigus, and also minimal suppression of HPA axis. Coming to triamcinolone, potent and selective glucocorticoid. It is used as intra-articular injection. നമ്മൾ ഇത്രയും പറഞ്ഞ സ്റ്റിറോയിഡ്സിൽ the one which is having an intra-articular injection form triamcinolone ആണ്. If you ask me example for where it is used, usually in the in dermatology where there is keloid formation. Keloid എന്ന് പറഞ്ഞൊരു കണ്ടീഷൻ ഉണ്ട് സ്കിന്നിൽ. നമ്മൾ സ്കാർ വന്നു കഴിഞ്ഞിട്ട് സ്കാർ ഓവർ ഗ്രോത്ത് ഉണ്ടാവും. That such lesions are known as keloid. So for prevention, അത് എടുത്തു കഴിഞ്ഞാൽ there is a chance of recurrence. At the those area നമ്മൾ triamcinolone injection കൊടുക്കാറുണ്ട്, so that there is no overgrowth of such scars. Okay, triamcinolones are usually used at such situations. Then coming to dexamethasone. Here dexamethasone is a potent, highly selective, long-acting glucocorticoid with a marked HPA axis suppression. They have significant HPA axis suppression with actions like inflammatory and anti-inflammatory and anti-inflammatory and allergic conditions. They use in inflammatory and allergic condition with and also in shock and cerebral edema. Last study uses ആണ് anti-inflammatory action കൊണ്ടും allergic action കുറയ്ക്കാനായിട്ട് ഉപയോഗിക്കും. Then in shock and cerebral edema. Fludrocortisone, the main difference is that this has a potent mineralocorticoid activity when compared to glucocorticoid activity. So it is used in replacement of aldosterone in Addison's disease where there is deficiency of aldosterone. It is also used in congenital adrenal hyperplasia where there is deficiency of aldosterone, and also in idiopathic hypotension. In idiopathic hypotension എന്ന് പറയാൻ കാരണം mineralocorticoid has the property of increasing BP. So it is used in idiopathic hypotension. Idiopathic കാരണമില്ലാത്ത ഹൈപ്പോടെൻഷനിൽ നമുക്ക് മിനറലോകോർട്ടിക്കോയിഡ് കൊടുത്ത് BP കൂട്ടാം. Therapeutic uses. What are the uses of glucocorticoids? Now, physiological doses of corticoids are used for replacement therapy. Wherever there is absence or deficiency of enzymes, so not enzymes, where an deficiency of hormones, we give replacement therapy. Supraphysiological doses are used for their anti-inflammatory actions and immunosuppressive effects in organ transplant patients and those autoimmune disorders. ഈ organ transplant ഉള്ളവർക്ക് നമ്മൾ organ transplant ചെയ്ത് കഴിഞ്ഞാൽ what is the first thing that we suspect is rejection prevent ചെയ്യാനായിട്ട് immunosuppressive effect വേണം. That is provided by corticosteroids. And also in autoimmune disorders where there are other immunological property which produces autoantibodies, ആ ഒരു ഫംഗ്ഷൻ തടയാനായിട്ടും ഈ corticosteroidsന്റെ immunosuppressive effect will be helpful. Okay. Coming to replacement therapy, we replace glucocorticoids or corticosteroids where there is insufficiencies. So first one, adrenal insufficiency. Adrenal insufficiency can be of two types, that is acute and chronic. Now acute adrenal insufficiency is an emergency situation which may occur due to the sudden withdrawal of steroids after prolonged use. So and chronic may be due to other infections like chronic infections, tuberculosis, autoimmune adrenal disease, and after surgery, hemorrhage and AIDS. All these will lead to adrenal insufficiency which can be treated by replacing the required hormone that is mean deficient. Usually we prescribe with hydrocortisone. Now coming to congenital adrenal hyperplasia where we again require a replacement therapy. Now congenital adrenal hyperplasia is a genetic disorder due to deficiency of 21 beta hydroxylase enzyme. Okay, as a result there is a decreased adrenal steroids, and also there is no feedback inhibition of the pituitary and ACH secretion increases. As ACH cannot release the corticosteroids because they are not synthesized, it leads to the overgrowth of the adrenal gland leading to symptoms. Okay, then usually to overcome the deficiency, normal amount of glucocorticoid and mineralocorticoids may be produced if there is partial Now, what are the drugs that are specifically given for acute and chronic? In acute adrenal insufficiency, it is IV hydrocortisone and dexamethasone bolus infusion. We should monitor the CVP and short-term infusion of dopamine. Okay. Now, chronic adrenal insufficiency, hydrocortisone orally. If needed, we can add fludrocortisone. As I told you, in congenital adrenal hyperplasia, hydrocortisone is selected and is given in divided doses 6 mg per kilogram. And also, if there is salt wasting that persists, then we can go to fludrocortisone, that is 10 to 20 microgram per kilogram. Okay, with this slide we can end our class. And ഇത്രയും പറഞ്ഞത് endocrine uses of endocrine uses of ഗ്ലൂക്കോകോർട്ടിക്കോയിഡ്സ് മാത്രമാണ്. അതായത് അവർ ഡെഫിഷ്യൻസി ഉണ്ടാകുമ്പോഴത്തേക്ക് എവിടെയൊക്കെ നമുക്ക് ഗ്ലൂക്കോകോർട്ടിക്കോയിഡ്സ് ഉപയോഗിക്കാം. ഇൻ മൈ നെക്സ്റ്റ് ക്ലാസ് ഐ വിൽ ബി ടീച്ചിങ് അബൌട്ട് ദി നോൺ എൻഡോക്രൈൻ യൂസസ്. വേറെൽസ് ഇതല്ലാതെ ഡെഫിഷ്യൻസി ഇല്ലാത്തടത്തല്ലാതെ വേറെ എവിടെയൊക്കെ നമുക്ക് ഗ്ലൂക്കോകോർട്ടിക്കോയിഡ്സ് കൊടുക്കാമെന്ന് ഇത് നെക്സ്റ്റ് ക്ലാസ്സിൽ നമ്മൾ നോക്കും. Now today what we studied is biosynthesis and regulation of glucocorticoids or corticosteroids. Mechanism of action of corticosteroids ഞാൻ പറഞ്ഞു, 2 റിസെപ്റ്റേഴ്സ് ഉണ്ട്. ഗ്ലൂക്കോകോർട്ടിക്കോയിഡ് റിസെപ്റ്റേഴ്സ് ഉണ്ട്, മിനറലോകോർട്ടിക്കോയിഡ് റിസെപ്റ്റേഴ്സ് ഉണ്ട്. പിന്നെ അവരുടെ ആക്ഷൻ ഇൻറ്റൻസിറ്റി ന്യൂക്ലിയസ് ഞാൻ പറഞ്ഞു തന്നു. ദെൻ ഫ്യൂ ഇൻഡിവിജ്വൽ ഏജൻറ്റ്സ് ഞാൻ പറഞ്ഞു ഗ്ലൂക്കോകോർട്ടിക്കോയിഡ്സിൻ്റെ. പിന്നെ ആൻറ്റി ഇൻഫ്ലമേറ്ററി ആൻഡ് ഇമ്മ്യൂണോസപ്രസീവ് ആക്ഷൻ ഓഫ് ഗ്ലൂക്കോകോർട്ടിക്കോയിഡ്സ്. ഐ ഹോപ്പ് ദി ക്ലാസ് വാസ് better and easier for you to understand. Please write your attendance, your name and roll number below in the comment box so that we can mark the attendance. കാണാത്തവരെ നമ്മൾ ഒരിക്കലും മാർക്ക് ചെയ്യുന്നില്ല, നമ്മൾ കറക്റ്റായിട്ട് നോക്കി എല്ലാവരെയും മാർക്ക് ചെയ്യുന്നതാണ്. പ്ലീസ് റൈറ്റ് എ name and roll number. Okay, see you in my next class. With this I am ending my class here. Thank you.